Well, I want to thank you for allowing me to speak at this beautiful facility and great gathering of people. It's an excellent talk to follow. So this is just our group, the myeloma group at the Mayo Clinic, at the SCCA, and I just wanted to throw up those pictures. So first of all, disclosures. I have none. Our goals today are to review the most important recent clinical developments in multiple myeloma, and essentially it'll be revealing how we practice at the SCCA. So I want to go over some very key basic points that have changed in multiple myeloma in the very recent past. And number one is that there are new diagnostic criteria in multiple myeloma, and I think anyone who treats the disease is aware of this, but it's making our lives a little bit more complicated. These were recently released by the International Myeloma Working Group in 2014. The old CRAB criteria we're all used to, greater than or equal to 10% plasma cells in the marrow, hypercalcemia, renal disease, anemia, and bone lesions. But now something called myeloma-defining events has arrived. And this is patients, so the idea here, as I'll touch on in just a second, is that these people are going to have CRAB criteria or symptomatic myeloma in the very near future. It's been shown very clearly by the Mayo Clinic that patients who have 60% or greater plasma cells in the marrow have a high risk, approximately 80% of developing CRAB criteria within 2 years. Patients with a high free light chain ratio of 100 or greater, and that needs to be repeated at least once, have a significant risk, a little bit less than 80% in 2 years, but a 70 to 80% risk of developing myeloma within 2 years. And finally, more than one focal lesion on MRI, and that's on a bone marrow MRI. I just want to footnote that in that there's a very long list of how the MRI needs to be done. It's in that paper, and so you should work with your radiologist to make sure that their bone marrow MRI is being done according to the recommendations of the International Myeloma Working Group. And as I have noted up here, each focal lesion has to be at least 5 millimeters or more in order to count it. So I've spent a lot of time working with our radiology group. They really were not aware of these changes in the myeloma diagnosis, so you might spend some time to talk to your radiologist about it. So we've got some criteria that now pick up maybe 15 to 20% of patients with what was called smouldering myeloma, and used to be called high-risk smouldering myeloma. These patients are now called multiple myeloma and generally should be treated. And I'll talk about maybe a caveat to that. The goal for including these new criteria, the myeloma-defining events, is very easy to understand. Originally, when we didn't have very many options for treatment in multiple myeloma, treating early did not make sense. All we had really was melphalan, stem cell transplant, and so intervening early did not make sense, and there were studies showing that it didn't work. But now that we have much more tolerable drugs and very highly active drugs, the goal is to intervene before the development of end organ damage in multiple myeloma. And these biomarkers that I just mentioned can help us to identify who these patients are that are high risk. And I'm going to talk a little bit about that as I move on to smoldering myeloma in a section or two, but be aware of the MDEs, and then we're going to talk about in a section or two when you might or might not move ahead with treating them. Currently, the recommendation by the IMWG is to treat them, but that's doesn't necessarily have to be done. Second point I want to bring to your attention is that there's a new staging system for multiple myeloma, and I think it's a very important development because it gives your patients much better information about how they're going to do. The international staging system is, I think, almost 15 years old. It was done before there were most of the cytogenetic markers that we have available now were available. So this new staging system combines the original ISS with chromosomal abnormalities, and I'll And those are the 414, 1416, and del17p as high-risk cytogenetic abnormalities. In addition, by looking back again at several thousand patients, it was noted that an important risk factor that can help to differentiate patients is the LDH. So lactate dehydrogenase should be measured at diagnosis along with chromosomal abnormalities to calculate a revised ISS prognostic score, and give your patients the best prognostic information available. This is the new system. Palumbo from Italy published this, and you can see that a large number of patients were used to generate this score, 3,000 to 4,000, and it's still very easy to use, just slightly more complex than the previous system. You still use the standard ISS staging that you did in the past with beta-2 microglobulins and albumin, but to be in the ISS1, the best group, you have no high-risk chromosomal abnormalities. That's what CA stands for, and those are the what are now considered to be the highest risk. There are many other chromosomal abnormalities like 1q+, 1420, that are under investigation, but at this time an international consensus group felt that the best data was for these chromosomal abnormalities, and therefore I think for purposes of consensus and prognosis, these are the ones I really focus in on. It's not that I ignore the others, but there's much more data and stringent data on these. That's the lowest risk group. Then the highest risk group is patients who are ISS stage 3 and have a high LDH or high risk cytogenetic or chromosomal abnormalities. And stage 2 is everything in between. Well, how does this matter? Why do we care? Amazingly, I think the stage 2 group is what really is surprising. And when I first shared this with some of my colleagues, they were flabbergasted. It turns out, so even if you have del17, if you're diagnosed at ISS stage 1, you still have a reasonably good overall survival based on this data of 3,000 to 4,000 people. So you can see that the 5-year overall survival rate for patients in RSS2 is 62%, and that includes people with high-risk chromosomal abnormalities. So this is based on the use of newer drugs and stem cell transplant and looking at this prognostic data. So I think it's very exciting, and it now no longer means that everybody with del17 is only going to live 2 years. I think for many of us, the cytogenetics seem to trump everything, but that's not true if you're diagnosed at early stage. And I do see patients like that. These are just the curves, and again on the top you can see here's PFS. You can see it's quite good for the stage 1, pretty good for stage 2, and the stage 3's very rapid recurrence. The overall survival is 50%. It wasn't even reached on this study, the median overall survival. So more than 5 years for patients with high-risk cytogenetics and ISS stage 2. So back to the question that I touched on a minute ago, patients with smoldering myeloma, should they all be treated? And this is a big challenge for hematologists, oncologists right now to decide what to do with these patients. And the bottom line is it's still quite controversial. This is long-term follow-up on the paper that originally stirred up everything 2 or 3 years ago from Dr. Mateos in Spain. And this is a 75-month follow-up, I believe, on these patients, about 110 patients, half of whom were treated with lenalidomide and Dex, and the other half were treated with observation alone. And the endpoint was progression. That was the primary endpoint that was studied. The treatment with lenalidomide was essentially standard treatment, lenalidomide 25 milligrams plus Dex. Now, their definition in Spain of what constitutes high-risk smoldering myeloma is different from what's used by the Mayo Clinic or other investigators for high-risk smoldering myeloma. They, first of all, one of the key differences is that they look at the phenotype of the abnormal plasma cells, and you have to have, in order to be high risk, 95% of the plasma cells need to have an abnormal phenotype by flow cytometry, and you also need to have immunopoiesis, this is in smoldering myeloma, of at least one of the uninvolved immunoglobulins. So it's a unique definition that's not used outside of Spain, really. And I think it'd be hard, you'd have to really talk to your flow cytometrist to get this particular data. We don't generate it in our lab right now, although we could. So the reason that in their hands, in their laboratory, patients who have these two risk factors, paresis of the immunoglobulins and a high abnormal phenotypically abnormal cells, have about 2 years to progression to good old-fashioned CRAB, whereas those who do not have a much longer period of time to CRAB. And again, the idea is, can we avoid waiting until people have renal failure or severe anemia or a pathological fracture? This is the time to progression to CRAB, and you can see that there's a dramatic difference here in the treatment group versus the observation group. Very exciting results, but a very small group, small cohorts of patients. But this has led to the suggestion that perhaps we should be treating patients with high-risk smoldering myeloma early. And remember that this, by the way, this study was started in 2007, so a lot of the developments in smoldering myeloma have occurred since this study was kicked off. The study's pretty old. It's 9 years old when they just published their most recent paper. So in addition to the progression-free survival benefits, or the progression to myeloma benefits, in the 75-month follow-up, there was a significant difference in survival. So even more exciting information that this could be a way to go. There are concerns, many of them regarding the study. It's an old study, as I've mentioned. Things have changed since 2007. We've got new technologies to follow patients. We've got new treatments. And not only do we have new biomarkers like the free light chains are much better understood, and we have things like bone marrow MRI, CT PET, and whole body CT, low-dose CT, which is not that available in the US, but it probably will be eventually. Ways to follow patients for the development of CRAB. It was suggested by a commentator on this long-term follow-up that patients with smoldering myeloma should have a PET CT or a whole body low-dose CT at baseline to rule out, to look for lytic lesions that are not detectable by plain films. We can now monitor very well patients with smoldering myeloma by looking at their free light chain levels, and that's a very powerful indicator that was looked at strongly by the Mayo Clinic. They can give us early signs for progression. The patients in the observation group of the study were treated only after developing CRAB criteria, but we could use a different strategy where patients are treated earlier than before their hemoglobin is fallen by 2, or their creatinine is 2, or they have multiple lytic lesions. So could we use an in-between strategy rather than waiting for the old-fashioned CRAB criteria? Again, the whole idea is to prevent harm. And so the use of an intermediate approach where patients are being followed closely using the new imaging techniques and free light chains, examining patients, et cetera, might have resulted in an earlier start of therapy instead of waiting for classical CRAB, and that might have avoided some of the treatment-related toxic deaths that were seen in the study. So that was an important part of the mortality side, the mortality side in the observational group. So should all patients with what was formerly called high-risk myeloma, getting back to should patients with MDEs, forgetting the Spanish study, the Mateos study, which is very important and provocative, but should patients with MDEs, this is what you're facing in the clinic, with more than one focal lesion by whole body MRI, patients with a high serum free light chain ratio that's been repeated at least twice, or patients with more than 60% plasma cells in their marrow, should they all be treated? And that's currently the suggestion. That is the recommendation of the International Myeloma Working Group. Well, yes, of course, we're preventing harm. That would be one answer to this question. And certainly I'm all for that, rather than waiting for patients to have serious complications. But another side of it is a significant number of these people, perhaps 20% of patients with what would be defined as having MDEs, still do not need treatment for years and can smolder for 5 years or even more. So could this mean we're over-treating 20% of patients, people who never needed treatment? Remember that this is what I tell people, and I tell the fellows, is once we put a patient on the myeloma train or the myeloma bus, they never get off. So they're going to be on chemotherapy for the rest of their lives. They're going to be sent for stem cell transplant, and it's a heck of a sentence to give to patients. So there's no easy answer here, but I worry a lot about treating patients who didn't need it. That's a question, of course, in all malignancies. So more research is needed. What do we do at the SCCA with patients who have MDEs but don't have classical CRAB criteria? We treat each case individually. We talk to the patient about the pluses and minuses of treatment and the risks of getting treated versus not getting treated, and we make the decision together. We do observe some patients, although someone with MDEs, clearly we're going to observe more closely, see them every month or at the most every other month. In 6 months, if, say, they had 2 focal lesions by MRI, but nothing else, and they just look great, we might repeat a whole body MRI. We'd get a CT PET to make sure there are no lytic lesions. Remember that a MRI really doesn't tell you if there's a lytic lesion or not. You can only see lytic lesions with plain films or CT scans. So that can confuse you. So we look at each case individually and debate it as a group. Moving on, is there some changes in our approach to treatment, and I think really in the approach around the country, is there a best induction therapy for multiple myeloma, and what is that in 2016? This is an important study that is felt widely to have changed the landscape for how we should approach newly diagnosed multiple myeloma in the United States. And this is a cooperative group study, the SWOG 0777, presented by Dr. Dury at ASH in 2015. And what this really looked at was Revlimid Dex versus Velcade Revlimid Dex in newly diagnosed multiple myeloma patients. And some of the patients, you did not have to be a non-transplant candidate to be a candidate for this study. After receiving 8 cycles of VRD or RVD, depending on how you prefer to say it, and this was standard VRD as Dr. Paul Richardson originally published it in his cohort of 64 patients. So it was 1, 4, 8, and 11 rather than once a week. What I do now when I'm using VRD is I'll give 1.5 milligrams of Velcade subcutaneously once a week, 2 weeks on, and then the patient will have 1 week off. But it's standard VRD, 8 cycles of VRD versus 6 cycles of RD, and that's because these are 21-day cycles and these are 28-day cycles, so the duration of treatment is the same. And then Revlimid Dex maintenance, so not standard maintenance as we've been practicing it for a number of years, which is generally, we sort of, many oncologists have used, including myself, the post-transplant type maintenance with 10 milligrams of Revlimid, 10 to 15 milligrams of Revlimid. But instead of that, Revlimid and Dex maintenance until toxicity, withdrawal, or relapse of the disease. And these are the results of VRD versus RD. Progression-free survival was significantly different in the Velcade Rev Dex arm, as was overall survival. So this is the first phase 3 study, a critical phase 3 study now showing the benefit, a clear benefit of the RVD combination versus Revlimid and Dexamethasone for the upfront treatment of multiple myeloma. Now, it doesn't come without a price, and we all have a love-hate relationship with Velcade, and that's because of the neurologic complications or the neuropathy. So neuropathy was significantly higher in the RVD arm, but it was not unacceptable. And of course, because Velcade is such a great drug otherwise, we continue to use it. Hopefully we'll have something to replace it in the upfront setting in the not too distant future. But there was more neuropathy in particular. I think that's the most important signal toxicity-wise out of that study. So the conclusions, conclusions for the study are that RVD or VRD with RD maintenance improves PFS and overall survival as opposed to just Revlimid and Revdex. They're both safe, but there's more neuropathy and some GI effects in the RVD arm. I have to say my patients on RVD or VRD do really well. So Dr. Dury presented this as a potential new standard of care for newly diagnosed myeloma. I think that line is supposed to go through potential for me. This really is a new standard of care, and I think in the Mayo Clinic MSMART guidelines, RVD is now their recommended upfront therapy for newly diagnosed multiple myeloma, both for transplant and non-transplant candidates. And the NCCN guidelines gave this a grade 1 recommendation. So I really think this should be our go-to therapy for all patients. I know there's still struggles with some insurance companies, but this really is the new standard of care in my mind. Now, relapsed refractory multiple myeloma, this really is where the mess is really going in multiple myeloma now because we have more drugs. The number of combinations has gone, potential combinations has gone through the roof, and so it makes it very challenging to decide how to treat a patient with relapsed multiple myeloma. How do we sequence and which choices? There are no clear pathways for the treatment of multiple myeloma at this time, unfortunately. I think at least newly diagnosed myeloma, we do have pretty clear choices in my mind. But where to go and how to go in relapse disease is a challenge. So some things to think about when you're seeing these patients is that many patients are going to relapse while they're on lenalidomide maintenance, so that means they're refractory right off the bat, so you're dealing with somewhat more challenging disease. Many, but not all, are on maintenance therapy. And because of that, triplet combinations are the way to go. And I think in our group, that would be a routine practice for relapsed refractory disease as a triplet combination. Unless someone's frail, we're going to tend to use triplets rather than doublets in patients with relapsed disease, especially as they have had multiple relapses. Now, it's been very interesting being in academia and seeing what's happening out in the community because the drugs are available. Combinations are being used that well ahead of the research studies being completed, and I think that's generally been good. Patients have really benefited from aggressive treatment of their multiple myeloma with the new drugs, whereas there may not have been a phase 3 study yet to support their use. But it's interesting watching things happen very, very fast as soon as these drugs are released. So in early disease, patients who have just had one cycle of therapy or one line of therapy or just 2 or 3 therapies, if they're on a Revlimid Dex backbone or a Velcade Dex backbone, then if they're on a Revlimid backbone, adding Elotuzumab or a proteasome inhibitor would be the way to go. Let's see here, I can't see the slides that well, but you can see that the addition of Carfilzomib to Revlimid and Dex here in the ASPIRE trial gave a very nice improvement in progression-free survival. In adding Elotuzumab to Revlimid and Dex in relapsed patients gave a less of an impressive improvement, but still significant improvement in relapsed patients. And Ixazomib or Ninlaro also gave significant benefit to patients who had been on Revlimid and Dex prior to that. So adding any of these drugs is a good option in early relapse of multiple myeloma. I think it's important for us to keep in mind that the approvals for Ixazomib and Elotuzumab are for patients earlier in treatment. So it's possible that some insurance companies might say, well, your patient's relapsed 5 times, so we're not going to let you use Elotuzumab with Revlimid. So the current approval is for patients between the 2nd and 4th lines of therapy, I believe. So I would keep that in mind so you don't lose the option to use Elotuzumab. It should be used earlier rather than later in patients. Panobinostat has been a challenge to use, although we've had some success with it when we've run out of various options. Panobinostat can definitely, it's a unique drug, a histone deacetylase inhibitor. Its mechanism of action is very exciting, but it has a lot of side effects. As you can see here in the Panorama trial with Velcade, Dex, and panobinostat, there are significant problems with thrombocytopenia and gastrointestinal issues and fatigue. So it is a challenge for elderly patients to use, but it can be a successful drug for you. We are studying other histone deacetylase inhibitors at our center, like ACY1215, the name ruxolinostat, and there's very impressive results with some of these drugs, including panobinostat in selected people, so don't forget it. In the Endeavor trial, Carfilzomib Dex was compared with Velcade Dex, and there was a significant improvement with Carfilzomib Dex versus Velcade, as one might expect. So this is generally a preferred agent. I really like Carfilzomib, and I've had a lot of success with it treating relapsed and refractory patients, both in early relapse and late relapse. By the way, these are slides from the ASCO review, multiple myeloma. Please always keep in mind that whenever possible, patients should be looking at clinical trials. We have usually 10 to 20 studies available at the SCCA, and I'm sure wherever you're from, your local site or even your site will have important research studies with novel drugs. The landscape is becoming very crowded in myeloma, and we need to find the best drugs and apply them to these patients as soon as possible. So a way to think about early relapse, patients who've had 1 to 3 prior lines of therapy, if they haven't had an immunomodulatory drug, then we should clearly add one in. So give a drug with a new mechanism of action. If they have had an immunomodulatory drug, but were responding well and didn't progress on it, then you might consider going back to the original regimen or using a different IMiD like pomalidomide. In patients who were being treated on proteasome inhibitors, or the consideration for proteasome inhibitors, obviously someone who hasn't had one, that's a great drug to go to in early relapse patients. And patients who were responding well to proteasome inhibitor, you can repeat it. Remember, autologous transplant, we're going to come back to that in just a minute. Auto transplant can be done up front or as salvage therapy, and so that's always an option for part of your patient's treatment with multiple myeloma. If someone has stored their stem cells when they were diagnosed, they went on and had their stem cells stored, and for whatever reason the decision was made to postpone transplant and not to get it up front, I strongly recommend that they get it at first relapse. All of the data for benefit is in auto transplant for retaining the benefit is if you get it at first relapse. So you still retain the overall survival benefit as far as we know from retrospective studies when you get a delayed transplant. But if you wait until the second, third, fourth relapse of myeloma, we don't know as much about the benefit of stem cell transplant. So I strongly recommend my patients who delay it up front to get it the first time they relapse. In patients who are later in the treatment of their disease or double refractory, pomalidomide and Dex has significant success in those patients, and pomalidomide is a good agent and well tolerated for patients. Daratumumab is a very exciting drug, and we're seeing a significant number of people respond, often people who really couldn't use any other drug. It's well tolerated as a rule, and the clinical benefit rate is high. Clinical benefit meaning stable disease or better. So many patients, especially who've been multiply treated, I'll accept a stable disease because that's going to prolong their life. If a patient had a successful treatment with a treatment regimen in the past but has gone off of it, you might consider returning to it because some patients may regain their sensitivity to those treatment regimens. So just because they've had something in the past and they're late in therapy doesn't mean they won't respond again to something that worked in prior times, because a sensitive clone may reemerge. Interest of time, I'm going to move ahead a little bit. The bottom line here is that triplets are consistently better for early relapse, and I would argue for late relapse as well, if you can get them approved by insurance companies. Of course, as the disease becomes more resistant, the gains are a little bit more modest. We need many new research studies using the combinations of these drugs to find an answer. I've heard Keith Stewart say from the Mayo Clinic that we're just one drug away with multiple myeloma, and hopefully Daratumumab might be that drug, as we've got a lot of studies in the next few years to be done using combinations of old and new drugs, stem cell transplant, Carfilzomib, Daratumumab, Lenalidomide, histone deacetylase inhibitors. Potentially we can find breakthrough combinations for our patients with multiple myeloma and relapsed disease, either upfront or relapsed. So finally, I think I just want to touch a little bit on autologous stem cell transplant for multiple myeloma. Does it offer an advantage for patients with newly diagnosed myeloma in terms of progression-free or overall survival? It's a question that's been on everyone's mind for the last 10 years or so since the new drugs were released. Do the new drugs make transplant unnecessary? And there's 3 or 4 studies like this that have been done around the world. This is the International Francophone du Myelome, the French and the Dana-Farber Cancer Institute study, which is a study of almost 1,500 patients, half of them in France and half of them in the United States. And this data was, preliminary data was released at ASH in 2015. The layout of the study is that patients are, enter the study. Everyone has a single cycle of Revlimid, Velcade, and Dex. And after their first cycle of RVD, they are then randomized to either early transplant or delayed transplant. They then everyone then gets 2 more cycles of RVD, so everyone essentially gets 3 cycles of RVD, and then their stem cells are collected. The patients who are randomized to transplant get a stem cell transplant after 3 cycles of RVD. Now that may sound early, but in many of the studies in the last 2 decades, transplant has often been done after just a few cycles of induction chemotherapy. In some ways it's attractive to treat patients for 6 to 8 or 10 cycles with 6 or 8 or 10 cycles of Cyborg-D or RVD to try and get the level of the myeloma as low as possible. But that doesn't necessarily improve outcomes. Remember that no matter how low the level is, at least for today, patients are still not going to be cured with a stem cell transplant, and we're simply giving more chemotherapy when we do a stem cell transplant. So patients get their RVD for 3 cycles, stem cells collected, half of them get a transplant, they get 2 more cycles of RVD and then len maintenance. The other patients, the non-transplant patients, get 8 cycles of RVD and then identical len maintenance. And this is the data released by Dr. Attal in ASH. The progression-free survival was significantly different and met the study goals, and in fact the study was closed early because it met the study goals for progression-free survival. So demonstrating that autologous stem cell transplant with the new drugs, with our new benchmark therapy, RVD, is better than for patients who simply get RVD without transplant. Overall survival was the same, but it's still early, and so the overall survival data will be coming out over the next 1, 2, 3 years. The U.S. study is still finishing, and will be finished probably at the latest by the end of this year, accruing. And there's going to be an important difference between the U.S. and the French trial, and that is the French are giving only 1 year of maintenance Revlimid after stem cell transplant. In the United States, we're giving indefinite maintenance until relapse. So the survival benefits will be very important, and the second malignancy signal will be very important to look at via those two studies. They're almost identical, but the maintenance strategy is very different. So I'm just going to skip these as I'm out of town. Not out of town. I am out of town, but I'm also out of time. And I want to thank you very much for listening and for coming today.